Hello, this is Jeff Swenson coming to you from the University of Utah Orthopedic Center, and we are here to provide a recorded version of the double black diamond ultrasound anatomy lecture given at the 2011 University of Utah postgraduate anesthesia course. In this lecture, we would like to cover three broad areas. Number one, we'd like to look at how far and how fast we have come with ultrasound-guided regional anesthesia. Then we'd like to cover two very important anatomic areas and very clinically relevant areas, namely the interscalene area, a close look at the anatomy of that region, and also a close look at the anatomy in the femoral region, and to look at what we have learned from ultrasound. As recently as 2006, a review article in Anesthesiology entitled Perineural Infusion of Local Anesthetics stated the following: a problem with ultrasound is that although it works well for superficial nerves when it is not really needed, it is not sufficient to identify deeper nerves, especially in very obese patients where it is most needed. It is not likely to replace nerve stimulation for continuous nerve block. Only 3 years after the publication of this review article, the following meta-analysis was published in the British Journal of Anesthesia in 2009. This study consisted of 13 studies, 946 patients, and included randomized clinical trials from 1990 to 2008. In it, the authors determined that blocks performed with ultrasound guidance had higher success rates, shorter procedure times, faster onset, longer duration, and lower risk of vascular puncture compared to blocks performed with nerve stimulator guidance. The authors went so far as to state in their conclusions that none of the trials published to date has demonstrated superiority of peripheral nerve stimulation compared to ultrasound guidance. Safety has improved greatly with the advent of ultrasound. One of the most feared complications when performing a peripheral nerve block is of intravascular injection. And prior to the advent of ultrasound, we had three main ways of determining whether there was intravascular injection occurring. The first was observing the patient for signs or symptoms of intravascular injection. The second was observing the heart rate, since most practitioners use epinephrine-containing solutions. And lastly, most practitioners perform frequent aspiration to detect the presence of the needle in a vessel. Ultrasound has added three more layers of safety to this process, namely the ability to visualize anatomy, the ability to detect intravascular echo contrast or turbulence within the vessel when intravascular injection occurs, and lastly, the presence of tissue distension or a hypoechoic space on the visual field as local anesthetic is injected. We're going to look at an example of this. If we look at these two panels, on the right we see an example of an intravascular injection, and on the left we see an example of a normal injection. As we look at the example of an intravascular injection, we see that during this injection there is an absence of tissue distension. In other words, as we inject, we do not see any hypoechoic spaces appearing on the screen, suggesting that local anesthetic is disseminating into the tissues. At the same time, we do see intravascular echo contrast, which is a hyperechoic blush occurring within the vessel, representing turbulence as the local anesthetic is injected into the vessel. Contrast this to the image on the left, where we do see the appearance of hypoechoic space or tissue distension during injection, and there is an absence of any intravascular echo contrast. So these two loops, as we play them, vividly illustrate how we can look for and detect intravascular injection as we're performing blocks. There have already been studies showing that safety with ultrasound is greater with respect to preventing seizures than performing blocks without ultrasound guidance. In this study, published in Regional Anesthesia and Pain Medicine in 2009, which included over 5,000 patients, the significant difference between blocks performed without versus with ultrasound was a higher incidence of seizures. At our institution, we have performed more than 10,000 ultrasound-guided blocks without any patient having symptomatic intravascular injection. What about cost? If we look at the cost of performing a single injection nerve block using a standard 22-gauge needle with ultrasound, we can buy these needles for 16 cents a piece. The cost projected over 1,000 blocks would be $160. By contrast, a 22-gauge stimulating needle costs $13.80 each, with a projected cost over 1,000 blocks of over $13,000. This cost difference is even more apparent when we place catheters. Our cost for buying an 18-gauge simple introducer needle and a 20-gauge polyamide epidural catheter is $8.02. Even 1,000 blocks costs only $8,020. Contrast this to the cost of a 17-gauge stimulating needle and a conventional 20-gauge polyamide catheter being $21.80, or an annual cost of $21,800. If both a stimulating needle and stimulating catheter are used, the cost for 1,000 blocks jumps up to $57,500, or roughly the cost of 2 brand new ultrasound machines. In truth, ultrasound could be called the biggest loser since 2000, since the features of ultrasound include a decrease in cost of nearly $120,000 for a console machine in 2000 to $45,000 for the first compact machine in 2006. Resolution improved and cost decreased further in 2009 when compact machines became available for $25,000, and recently in 2010 handheld devices became available for approximately $8,000. You can see that the weight has decreased dramatically since 2000 as well, from 320 kilograms for a console machine to half a kilogram for a handheld device. We're going to look at interscalene anatomy now, as we promised. First, I would like to credit those who have taken part and been key members of our anatomy team performing fresh cadaver dissections. First and foremost, we'd like to recognize Dr. Daehan Jo from the Republic of South Korea. Also, Jennifer Davis, who is the head of our pain service at the University of Utah. Evelyn Luce, head of the member of our pain service and faculty member at the university. John Hill, anesthesiology resident. Josh Stream, anesthesiology resident. Smitha Warrior, former pain fellow and now faculty member. Byron Bankhead, who is one of the directors of this course and our faculty member. And last but not least, Dan Gammon, fellow in regional anesthesia. Some interscalene anatomic considerations. Nerves within the path of the needle in the region of the brachial plexus. Should we be not dodging them? How close is close enough when we approach the brachial plexus in the interscalene region? What do we do about a split plexus? There are at least three pure motor nerves in the interscalene region. Most of us are familiar with the phrenic nerve, which innervates the diaphragm. The dorsal scapular nerve is also present, innervates the rhomboids and levator scapula, as is the long thoracic nerve, which innervates C5-6 serratus anterior. If we look at a gross cadaver dissection, we can see the anterior scalene on the right, brachial plexus in the center, middle scalene on the left. We know about the phrenic nerve. We've talked about it before. It runs obliquely across the surface of the anterior scalene muscle and penetrates the connective tissue between the anterior middle scalene at about C6. One set of nerves we have not discussed at length, however, is the long thoracic and dorsal scapular nerves, which run through the substance of the middle scalene muscle. If you look carefully on your ultrasound when you're performing interscalene block, you can see this on almost every patient. This is a diagram showing what these nerves look like on ultrasound. So here we have the anterior scalene on the right, middle scalene on the left, brachial plexus in the center. The phrenic, when we are at the level of C6, is located over the brachial plexus in the interscalene groove. Within the substance of the middle scalene, in an oblique hyperechoic fascial plane, are the long thoracic and dorsal scapular nerves. If we look at their actual appearance on ultrasound, we can see in this example where we have the middle scalene on the left, the anterior scalene on the right, the brachial plexus in the center. These arrows illustrate the hyperechoic oblique tissue plane, which contains the long thoracic and dorsal scapular nerves. As we move the probe inferior and superior on the neck, they will move back and forth within the substance of the middle scalene muscle. This is another example of the same structures, with the anterior scalene on the right, middle scalene on the left, brachial plexus in the center, and we have here the arrows showing the long thoracic and dorsal scapular nerve in this oblique tissue plane. And once again, as we move the transducer up and down on the neck, they'll move back and forth. So you may say, what do I do different if I see these? Our practice has been, when we see them, to find a plane where we can advance our needle such that it does not cross the path of these nerves on the way to the brachial plexus. Some other considerations when performing the interscalene block are how close is close enough to the nerve. This is a picture of two stallions about 100 miles west of Salt Lake City in the West Desert, where we have a large herd of wild Mustangs. This picture was taken by John Steele of our pharmacy. If we look at the interscalene region in diagram form, we can see that one thing is missing from this picture, and that is when we look at a gross dissection of the neck, we don't see individual elements of the brachial plexus, in other words, upper, middle, lower trunk as we see here, but they rather are surrounded by connective tissue. So it's important to know that since the elements of the brachial plexus are surrounded by connective tissue, do we need to inject between the scalene muscle and this connective tissue? Is that sufficient? Or do we actually need to puncture this connective tissue and inject around the individual nerve roots, as seen here? This actually was the subject of some small amount of discussion in anesthesiology in 2008, which was initially started by a case report of severe brachial plexopathy after an ultrasound-guided block. The etiology of this injury is still not known. It is interesting to note, however, that the authors reported injecting anteriorly, laterally, and medial to the nerve roots and repositioning the needle 3 times in this depicted picture here, showing that the needle was perforated through the connective tissue and then individual injections were occurred to surround each individual nerve root with local anesthetic, with the message being, do we need to be that close to the nerve? And if so, is that going to offer any safety above doing it with a nerve stimulator? And the accompanying editorial in this same issue stated that there was some question about whether ultrasound provided any prevention of nerve injury compared to nerve stimulator techniques. In response to that, we also wrote a letter to the editor stating that with new techniques, we might want to consider adopting new methods that are further away from the nerve to confer some additional safety. But needless to say, this discussion is still ongoing. Does this technique work? If we stop short of the connective tissue surrounding the plexus, does it work? We actually published a study in 2009 where we looked at 200 prospective blocks which were performed this way, and indeed resulted in a success rate of 100% for single injections and 99% for catheters. This is an example of this technique. If you look, we have middle scalene on the left, anterior scalene on the right, and brachial plexus in the center. You'll see that as we advance our needle to the brachial plexus, the operator stops short of the connective tissue surrounding the brachial plexus right here, so you won't see any expansion of the connective tissue surrounding the brachial plexus, only expansion of the tissue plane between the middle scalene and the brachial plexus. So this connective tissue barrier that we see here, illustrated by the arrows, remains intact. This is a fresh cadaver dissection showing the tissue space that we inject into with the forceps. We have our forceps here between the middle scalene and the brachial plexus, and that is the plane that we inject into. You'll also notice that when we're looking at the brachial plexus, we don't see individual elements of the plexus, only the white conduit with the connective tissue surrounding those elements, and this is anterior scalene here. So this is the space injected into with the technique we just showed. This would be the connective tissue that you have to perforate to perform the block if you're going to inject individual elements of the brachial plexus. This is a close-up showing once again the space between the middle scalene and the connective tissue surrounding the brachial plexus. And in this case, we've incised the connective tissue around the brachial plexus, and you can actually see through the connective tissue now into the space and visualize individual elements of the plexus. The question being, with middle scalene here, brachial plexus within the connective tissue, do you want your catheter in this position or this position? The other question when we perform the block in this manner is, does drug get to the other side of the plexus? A lot of times when we're performing blocks this way, it's not readily apparent on ultrasound whether we have drug here or in addition here. If you look at this example again, you'll see that at the termination of this injection, you see drug between the border of the middle scalene and the brachial plexus, but it's not apparent whether there's any drug on the anterior scalene side. So in fact, what we did when we were looking at this in a cadaver study was to see if we injected only on this side and then dissected after injecting methylene blue, what do we see within this whole substance of the interscalene space. So here's an example of that. We're looking at the right side of the neck. We see anterior scalene when phrenic nerve here. Anterior scalene is outlined in white. The middle scalene here, and the interscalene space is visualized full of methylene blue dye that we injected through a percutaneous injection as shown in the ultrasound previous to this. In fact, when we open up that space, we can see that on the middle scalene side as well as the anterior scalene side, there is full distribution of methylene blue. So indeed, the methylene blue does spread throughout this space, even though we only injected on the middle scalene side. What about a split brachial plexus? A lot of times you will start at the clavicle, see the brachial plexus continuously in the same space, and as you move the transducer cephalad on the neck, elements of the brachial plexus may split off as seen here. If we look in this ultrasound, we're looking at just such a plexus. We're starting at the first rib and we see the subclavian artery, but as we move the transducer cephalad, watch what happens to the upper elements of the brachial plexus. They now wind up in the substance of the anterior scalene muscle, with the other elements of the brachial plexus within the substance of the middle scalene muscle, and the interscalene groove apparently containing nothing. You can imagine how frustrating this would be if you were performing this with a nerve stimulator. It would be very difficult to get any response when the plexus is split between the two scalene muscles. What we do in this situation is simply take the path of least resistance. We go to where we see the brachial plexus together and simply perform our block a little more inferior on the neck than we might otherwise. We want to look at the lower extremity now as well. And the first question we'd like to ask is, how does a 3-in-1 or fascia iliaca block work? Well, in 1973, Alan Winnie described the mechanism as being proximal spread to the lumbar plexus from below the inguinal ligament. This was changed in 2000 by Peter Marhofer to suggest that the actual mechanism was medial and lateral spread below the inguinal ligament. And many of you may say, well, who cares as long as it works? If you are attempting to get distribution of drug into the retroperitoneal space where the lumbar plexus is, this technique needs to occur. And if in fact it does occur, it could be an alternative to a posterior approach to the lumbar plexus block. However, if the actual mechanism is medial to lateral spread, this block would not function well as a lumbar plexus block. So we were interested in this several years ago. We did this injection without ultrasound guidance and did in fact see medial and lateral spread from the anterior superior iliac spine to the femoral nerve and beyond. which led us to believe that Peter Marhofer was indeed right until we performed the same block percutaneously while visualizing with ultrasound this tissue plane deep to the fascia iliaca, and injected 30 mLs of methylene blue and then performed a dissection. And you can see in this case that we have the iliac crest identified by the white line, and we're looking obviously from the inset picture at the left inguinal region, and the inguinal ligament is illustrated by this second white line, the anterior superior iliac spine down to the pubis. You can see from our injection point lateral to the femoral nerve that the distribution of dye was well into the retroperitoneum and up to the iliac crest. This is a closer picture here where we contrast the iliacus muscle on the diagram from Gray's Anatomy to the retroperitoneum illustrated by the retracted bowel and the iliac crest here, with the femoral nerve and also our injection point visualized here. So indeed, it appears that when we perform the block in the proper tissue plane, there is extensive spread into the retroperitoneum as high up as the iliac crest. There's a very relevant point of anatomy that I think needs to be mentioned now that we have had the advent of hip arthroscopy, and it represents a new variation for femoral anatomy. If we perform fascia iliaca block for analgesia after hip arthroscopy, there's a very significant difference between the appearance of the anatomy preoperatively and the appearance of the anatomy postoperatively. On the right, we see a preoperative image of the inguinal region in a patient where it's readily visible the femoral artery, the iliopsoas muscle, femoral nerve. However, the same patient postoperatively has distorted anatomy showing the femoral artery displaced inferiorly, the iliopsoas muscle displaced inferiorly, and the femoral nerve being very difficult to identify specifically. The interesting thing here now is that we have a tissue plane identified deep to the fascia iliaca that represents dissecting fluid that the surgeons use while they're performing the arthroscopy. And during this arthroscopy, dissecting fluid spreads between the ports all the way down to the joint space and in every tissue plane between. So not only is there swelling of the inguinal region, but all the tissue planes, including the plane of the fascia iliaca, becomes dissected and filled with normal saline. So this becomes very difficult to visualize. As we inject into the plane of the fascia iliaca, it's a little easier to imagine where anatomic structures are, and at the end of this injection, we see the relative position of the femoral artery and the femoral nerve outlined by the yellow circle here. So this would be a very frustrating block to perform with nerve stimulation, not only because the anatomy is distorted, but because the tissue is full of normal saline, which can alter the conducting properties of nerve stimulating needles. We'd like to end up with a discussion of the vascular anatomy in the inguinal region and things we have learned from ultrasound. This is another picture of John Steele of a couple of blue herons about 30 miles east of Salt Lake City. The femoral artery anatomy is going to be the last leg of this talk, I promise. This is a gross cadaver dissection showing the femoral nerve outlined with the letters FN in yellow, and the femoral artery here. A very common vessel we see on ultrasound that is an appendage of the femoral artery is the circumflex iliac artery, comes off laterally. More distal, we see the takeoff of the profunda femoris artery, and from the profunda femoris we see the lateral circumflex femoral artery. All of these vessels are potential places where we could either get an intravascular injection or a hematoma formation from inadvertent puncture. If we look first at the circumflex iliac artery, we can either see it in long axis as shown here, or in short axis as seen here. and you can see the position of the femoral nerve relative to the circumflex femoral artery or iliac artery. We also see the takeoff of the profunda femoris artery from the femoral. The profunda femoris takes off lateral and posterior to the femoral artery. It usually leaves about 3 to 4 centimeters below the inguinal ligament, but it can take off at or above the inguinal ligament, as in this case here. We see a very proximal takeoff of the profunda femoris with the relative position of the nerve. We're going to move proximal and distal with the transducer, and you will see the common femoral here, and as we move the transducer more distal, we see the takeoff of the profunda femoris. As we look here, we see the profunda femoris artery, and the takeoff from the profunda femoris artery is the lateral circumflex femoral artery, which is often misnamed and confused with the circumflex iliac artery, but the actual origin of the lateral circumflex femoral is from the profunda femoris. Here is a representation of their relative positions, and as we look, we actually have a very nice example of this on ultrasound. Here's the femoral nerve illustrated, and as we come up, we see the common femoral nerve, or common femoral artery, here. So here's the femoral artery. As we go distal, we see the takeoff of the profunda femoris, and as we go more distal, we see the lateral circumflex femoral taking off from the profunda femoris, and we see circumflex femoral artery here, femoral artery, profunda femoris, and femoral vein. So these are very important anatomic features to recognize and understand their relative positions to avoid vascular injection or trauma to the vessels or hematoma. Hopefully we will appreciate from these lectures that there's a lot more to the anatomy on ultrasound than meets the eye. In fact, if you take a close look at this picture, you'll see that this is not only a nice cliff, but there are tracks at the top of this cliff where Rachel Burks, the daughter of one of our orthopedic surgeons and a pretty famous big mountain skier, is about to jump off this. We appreciate your attention and thank you for your attendance at the meeting.